Hi everyone, Dr. REHMAN here from Connolly Hospital, BLANCHARDSTOWN. I'm working as SHO anesthesia via CPSP HSC program. I'm going to present my audit titled as Efficacy of Rectus spinae in Catheter-Based Analgesia Practice in Thoracic Surgery Patients. So what are rectus spinae? Rectus spinae are a group of muscles running from the sacrum to the base of the skull, supporting our spine. In rectus spinae block, we have to inject the local anesthetic in the myofascial plane between the transverse process and the rectus spinae muscle. It has the advantage of being considered even in the coagulation abnormalities. A systemic review done by the Ferrero et al. And Blanco et al. Reported favorable outcomes in favor of erector spinae block as it has opioid sparing effects and hence complementing the ERAS protocols. Data was collected using the non-probability consecutive sampling over the period of 1.5 years. Exclusion criteria includes local infection at insertion site, hypersensitivity to local anesthetics, and patient denial. Out of the 76 erector spinae catheters that were inserted, 68 were inserted using the ultrasound guided technique, 8 were inserted blindly. 32 times we had used the Tohei epidural needle to insert the of 16 gauge to insert the erector spinae catheter, and 44 times we have used the 18 gauge epidural Tohei's needle. So we have used different infusion concentrations. 0.1% bupivacaine is the most common one, and different adjuvants were also used, only 9 times, which includes the fentanyl and dexmedetomidine. Different volumes of infusions were used that are 10 ml per hour, 15 ml per hour, and 20 ml per hour. Most of the catheters were removed on the third day, but 2 catheters were even removed on the 6th day without any complication. There is no such complication other than being accidental removal of erector spinae catheter that happens in 5 patients. Out of those 76 patients, 1 patient expired. The reason was not erector spinae, it was due to surgical cause. All other patients survived. So here is the discussion part. We will recommend the use of local anesthetic bupivacaine with the concentration of 0.15% to 0.2% at the 15 to 20 ml per hour volume infusion with intermittent boluses before physiotherapy or movement with a concentration of 0.2% to 0.25% depending on the pain and the hemodynamics. Rectus spinae catheters can be kept in situ between 2.8 days to 6 days. The complication rate in our study is 0, which correlates with the study done by Oisel et al. In 342 patients. The limitation of our study is its retrospective nature, and results may not be the same for every center as it is a single center study. So the conclusion is that erector spinae muscles should be erector spinae block based catheter blocks should be the preferable mode of analgesia for thoracic surgery patients, as it is very much comfortable with patients with sepsis, coagulopathy, and systemic infections. Thank you.